Welcome to the American Liver Foundation's webinar series, Fatty Liver Disease from a Bariatric Surgeon Perspective. My name is Donna Shaka, and I work for the American Liver Foundation's Connecticut division as the Community Outreach and Education Manager. The American Liver Foundation's mission is to promote education, advocacy, support services, and research for the prevention, treatment, and cure of liver disease. Dr. Gedeon obtained his medical degree from the American University of Beirut in 2002. He completed an internship at Mayo Clinic in Rochester and a general surgery residency at the University of Texas Southwestern in Dallas, Texas in 2007. He is double fellowship trained, having completed a clinical fellowship in minimally invasive and bariatric surgery at the University of Texas Southwestern in Dallas in 2008, and a clinical fellowship in colon and rectal surgery at the New York Presbyterian Hospital in New York City in 2009. Dr. Gedeon joined the medical staff of Bristol Hospital, Bristol, Connecticut in 2009 and started the weight loss surgery program. He served as the medical director of the program until the end of 2018. His clinical interests include minimally invasive surgery, flexible endoscopy, and robotic surgery. His research interests include surgical technology and clinical outcomes in bariatric surgery. He is an active member of the American Society of Metabolic and Bariatric Surgeons. Dr. Gedeon is also a member of the American Liver Foundation's Connecticut Medical Advisory Committee. Dr. Gedeon, thank you for speaking.
Donna, thank you so very much. I am really very honored to be here today, and I really want to thank the American Liver Foundation for this opportunity to present and maybe enlighten a little bit people about the problem of liver fatty disease. I'm going to get started. The liver performs more than 500 functions. Liver is really an organ situated in the right side of the abdomen, on the top part of the right side, what we call the right upper quadrant. It does act like a filter, detoxifying substances that are harmful to your body. Also helps make bile to digest foods. Also has some role in clotting of the blood. As I mentioned, 500 functions. So what is non-alcoholic fatty liver disease? It is the buildup of fat in the liver. And so every liver has a certain amount of fat, which is normal, up to 5 to 10%. However, when the amount of liver fat goes beyond that, a person is considered to have fatty liver disease. Problem with fatty liver disease is that often patients have no symptoms. But when they do get symptoms, those include abdominal pain, nausea. Patients can have fatigue and weakness, itching, or even loss of appetite. Now, fatty liver disease is the most common cause of abnormal liver function tests in the United States, with an estimated 100 million Americans having non-alcoholic fatty liver disease and 25 million patients or people having what we call NASH. And we're going to be talking about what NASH is. It's a little bit of a more advanced form of fatty liver disease. And many people with type 2 diabetes and the majority of people with obesity have non-alcoholic fatty liver disease or NASH. On the right side, you can see how a normal liver would look like. It's a really pink and smooth surface. This is what a normal liver looks like. Non-alcoholic fatty liver disease and NASH are a spectrum of the fatty liver disease. On the right side, you can see a fatty liver, the yellow coloration in it, and fatty infiltration. The problem is the fatty infiltration can cause inflammation. And the inflammation with time can scar and become fibrotic. And when it is very severe, you can have what we call liver cirrhosis, which is severe scarring of the liver. And in extreme cases, you can have what we call you can have liver cancer, pretty much, hepatocellular carcinoma. So it's really a spectrum of disease going from from the normal liver down to liver cirrhosis. Okay. Risk factors for fatty liver disease: we have obesity, we have type 2 diabetes, high cholesterol, high triglycerides, as well as certain medications. How do we diagnose fatty liver disease? Fatty liver disease is often a diagnosis of exclusion. So when you have a patient who has the risk factors, for example, obesity, type 2 diabetes, you suspect non-alcoholic fatty liver disease, and especially when the blood work is abnormal. You can get, or we can get imaging tests to show that. Ultrasound and MRI are also helpful. There is a certain type of imaging technique called the fibroscan, which looks into the liver and the scarring of it. But it's very important to note that the liver functions are normal in up to 30% of people who have non-alcoholic fatty liver disease. And so up to 1/3 of people can have normal liver functions. The treatment for non-alcoholic fatty liver disease, there is currently no medication that's been proven to be definitively beneficial. But weight loss has the most impact on this disease. Now, how do we lose weight? Weight loss can happen through either lifestyle modification, through diet and exercise. However, when the obesity problem is severe enough, where diet and exercise do not work anymore, surgery is usually reserved for patients who qualify. We're going to be talking a little bit more about that. It is very, very important to remember that alcohol makes liver disease worse. So, abstaining from alcohol consumption is so important. What about obesity? This is going to be really the focus of the talk today. Worldwide, obesity has tripled since 1975. Currently, there's 1.9 billion adults who are overweight. 650 million are obese. It's important to know that obesity is preventable. How do we define obesity? WHO defines obesity as a condition of abnormal fat accumulation where health is impaired. And so, again, just like with NASH, every organ system or every individual has a certain amount of fat in their body. However, when fat reaches a point where your health is impaired, is when we talk about obesity being a problem. This is obviously a very subjective definition. As scientists and as doctors, we like to be a little bit more objective. And so we talk about something called the BMI. The BMI is really, the formula of the BMI is the weight in kilograms divided by the height in meters squared. In simpler terms, BMI is the weight to height ratio. A couple of important numbers. The normal BMI is BMI of between 18 and 25. Anything below that, for example, a BMI of 17 is considered underweight, and anything above that is overweight. BMI above 25 is overweight. BMI above 30 is considered obese. And the obesity is classified also into categories. We're not going to go over the categories, but the important numbers are BMI at 25 and BMI above 30. Okay, any BMI above 30 is considered obese. If we look at the prevalence of obesity in the United States, this is in the from the CDC. Those slides are obtained from the CDC, and 2011, for example, I'm going to show you several years. 2011, you can see the prevalence of obesity in the United States, and as we come closer, the obesity problem has gotten worse. Darker means worse. The map is getting really darker and darker. And so if you look at the several different states, I live in Connecticut, for example, and the prevalence of obesity, self-reported here, is around 26%. Obesity is more than the weight itself. If you look at obesity being in the center of the problem, now I should say that obesity itself is now considered a medical problem, and so the American Heart Association recognizes obesity as being a problem by itself. But if we look at obesity as the central part of the issue, every single organ system in the body is affected. For example, the cardiovascular system, you can have high blood pressure, heart disease. For the pulmonary system, you can have sleep apnea, asthma, metabolic, you can have diabetes, high cholesterol, fatty liver disease, so on and so forth, neurologic, tumor, cerebral headaches, psychiatric depression, anxiety, skin problems, societal discrimination, etc. Even the risk of cancer is increased because of obesity. But when it comes down to it, it's really about the risk of mortality and longevity with obesity. If you look at somebody who has a normal BMI between 20 and 25, and you consider that the risk of death is 1, As we go up with the BMI class, we will note that the risk of death goes up. So it's 2.5 times the risk in somebody who has a BMI of 35. So it's really about your health and the risk of mortality. That obesity is an important problem. What causes obesity? It's really an imbalance between the energy intake and the expenditure over a long period of time. Simplistic definition is calories in minus calories out, but it's really more complex than that. But contributing factors are increased amount of fat and caloric intake in the diet, especially carbohydrates, as well as the reduction of the level of physical activity. Problem is that once weight is gained, physiologic processes in the body developmentally tend to maintain the new weight. So the human body has been kind of developed in a way to gain and retain energy. So once you gain weight, it's very, very hard for you to lose it. The treatment of obesity follows several parts. First and foremost, most important is prevention. Then lifestyle modification through diet and exercise. Then we have medications, and finally we have surgery. Today I'm not going to talk about prevention or pharmacologic treatment, but I'm going to really focus on lifestyle modification, diet and exercise, as well as surgery. Concerning diet, this is the old food pyramid. What the USDA used to recommend is to drop the amount of fats and carbohydrates. Currently, we use and we recommend a little bit more of a balanced diet, where fruit, vegetable, protein, and grains, as well as dairy, are better balanced. This is for somebody who has not had a weight loss surgery. As a matter of fact, for bariatric patients, the plate actually changes, and I can tell you, for example, the protein constitute a bigger percentage of the plate. Bottom line, to be able to lose weight, you got to eat a balanced diet. Some recommendations: choose less carbohydrates, choose less sugary drinks, choose less junk food, fast food, fatty foods, and choose more vegetables, cook your own meals, etc. Some other tips: increase foods that are rich in vitamin E. As I mentioned, make your own food, cook your own food, and because that's been shown to kind of help with the portion control. What about exercise? Concerning the exercise, I'd like to mention what the American Heart Association recommends, which is really 150 minutes of exercise a week, and this is moderate intensity exercise. Alternatively, you could do 75 minutes of vigorous aerobic activity. So that's around an hour and 15 minutes. The other tip is that any activity that you do throughout the day is much better than none. Cardiovascular exercise is so important. All of those will help increase your mood, improve your mood, help you sleep better, and help with other activities such as memory, balance, cognitive abilities, etc. So this was really a very small kind of primer on diet and exercise. Now, what about surgery? So the rationale for surgery is the following. So there was a study that was done in Sweden. It's called the Swedish Obesity Study. The nice thing about the study is that it took a lot of patients from multiple centers, and they divided the patients into two groups. One group was the medical arm, and those patients wanted to lose weight, okay? So the medical arm, which you can see on top, were very motivated patients. They did the best diet, best exercise, and they took their baseline weight, and they followed them over a period of time, which is around 10 years. And so as you can see, at the 6-month mark, those patients lost weight, but then when you follow them for 10 years, they were actually a little heavier than when they started. This is the medical arm. The bottom 3 lines represent the surgical arms. So those patients picked to have surgery. They said, we're just going to go for surgery. So they had the operation done. They lost weight. They regained some over 3 to 5 years. But then if you look at 10 years, you can see a significant difference between the medical and the surgical arm. This is just to kind of demonstrate that surgery is a sustainable option, meaning it's not only a quick fix. You know, you have the operation, you might regain some weight, but on the long term, surgery as compared to diet and exercise is significantly better. Okay, and this is really what constitutes the rationale for surgery. For what we do when we tell patients bariatric surgery or weight loss surgery is a sustainable option for obesity. The number of bariatric operations have really increased exponentially, especially over the past 30 years. There are three main reasons. You know, in the early 90s, there were around maybe 20,000 operations, and then up to 200,000 operations per year. And this has plateaued, went down a little bit, and now it's really plateaued. What's the reason for that? There are, I think, three main reasons. Number one, which is the obvious, is that the prevalence of obesity has increased, and so there's more people who actually qualify for surgery. So that's one reason. Second reason is that in the early 90s, the NIH, National Institute of Health, met and said, you know what, we're going to put the guidelines on who qualifies, who doesn't for bariatric surgery. Interestingly, we still follow those guidelines today. And I'm going to be talking about what those are. And then a third is that the field of laparoscopy, through very prominent surgeons in California, was actually introduced to bariatric surgery. And so bariatric surgery that was done through open incisions in the 70s and 80s was now done through laparoscopy or keyhole incisions. So the same effect was obtained, however, through less invasive or minimally invasive techniques, which was obviously to the advantage of the patient. So what are those NIH criteria I was talking about? The NIH criteria are the following. Remember the BMI that we spoke about. If your BMI is above 40, then you are a candidate for bariatric surgery, whether you have comorbidities or medical problems or not. So if your BMI is above 40, you qualify for surgery. On the other hand, if your BMI is above 35 and you do have comorbidities, what do I mean by comorbidities? Comorbidities are those medical problems we spoke about when we showed the circle: high blood pressure, diabetes, hypertension, diabetes, cholesterol, etc., etc. You should have shown commitment to surgery, and you should have attempted non-surgical weight loss methods, meaning have seen a dietitian. As I mentioned, the operations are done minimally invasively through keyhole incisions, and the operations are done today either laparoscopic or even robotic for patients who qualify. The important thing to realize is that those are done minimally invasively with a quick recovery. So the two operations I'm going to be speaking about are the sleeve gastrectomy or vertical sleeve gastrectomy, as well as the gastric bypass surgery. The sleeve gastrectomy is what we call a restrictive procedure. Restrictive procedure meaning it restricts the amount of food that you can ingest. So if you look at this schema here, this is the stomach. It's divided up and down, okay, and this part is removed out of the patient or out of the abdomen and sent to pathology. Bottom line, you're left with a banana shape of stomach, and this can hold around 100 cc's or 3 ounces of food. The sleeve gastrectomy started with a bigger operation called the duodenal switch, but now the sleeve is performed as a primary surgical operation, meaning it's offered as a procedure by itself. In the past, when we used to say it had the shortest track record as compared to the other operation, however, today we say it is the most common weight loss operation in the United States. And it has two components to it. It has a restrictive component. Like I mentioned, this part over here holds less food than the total amount that would be normally in the stomach, and so you eat less. By eating less, you would lose weight. But it also causes a decreased hunger. Now, this part of the stomach that is removed carries cells that secrete a hormone called ghrelin. And the ghrelin can cause hunger. So when you're less hungry, you tend to eat less. As I mentioned, the operation can be done either laparoscopic or robotic. It is interesting to know that the complication rate of the sleeve gastrectomy is around 2 to 3 times less than the complication rate with the gastric bypass. This is a picture of intraoperative picture with permission of sleeve gastrectomy. This is how it looks in the operating room. This is how the stomach was You can see the color of this is darker. This is because the blood supply has been cut off. This segment will be removed out of the body, and this is what's left, which can hold less food. This is how it looks on the inside through endoscopy. As I mentioned, sleeve gastrectomy can be done either robotic or laparoscopic. Stay in the hospital is usually 1 night. What about the gastric bypass? So when you ingest food, this is the normal anatomy on the left side. This is the gastric bypass anatomy on the right side. When you ingest food, the food goes into the stomach and mixes with the acid of the stomach, gets ground up, and it gets pushed into the intestine, the duodenum, which is the first portion of the intestine, where absorption and of the nutrients happen. What happens with the gastric bypass, and bear with me on this, is we divide the stomach with a small pouch, we divide the intestine, and then we reconnect things together. This part of the intestine is connected to the pouch, as you can see on the right side. And this part of the intestine is connected downstream, as you can see on the right side. So that same food, instead of traveling into the stomach, into the normal route where it gets absorbed, travels straight down, bypassing the segment of absorption. This is why we call it the gastric bypass, because it bypasses the segment where absorption of food happens, or absorption of some of the food happens. And so this is the gastric bypass component. On the other hand, because we divided this into a small pouch, this is a restrictive component. So there are two components that are important. There is the restrictive component and there is the malabsorptive component. It is the second most common operation performed in the United States today. It is both restrictive and malabsorptive, and it's done also through minimally invasive techniques, either laparoscopic or robotic. It does have 4 effects. Again, there is the decreased portion size because food gets stuck over here. So instead of eating an X amount of food, you eat a fraction of that and you get full because the pouch cannot hold more than 1 to 3 ounces of food, usually around 1 ounce. There is the malabsorptive component where instead of food traveling in the normal route where it's absorbed, it travels straight down, bypassing the segment. There's also hormonal changes around the pancreas especially, and this is why it has significant benefit in patients who are diabetic. There's also an effect called the dumping syndrome. Dumping syndrome is patients usually get sick when they eat refined sugars. What about the outcomes? There are several ways through which we look at outcomes for weight loss surgery. We can look at either weight loss. This is an outcome. A complication rate is another outcome. The control of the comorbidities is a third outcome, meaning how well did we do in controlling the medical diseases that come that are associated with obesity. And then finally, there are what we call the non-scale victories. Non-scale victories are very hard to define, but they include things like, hey, I can run around, I can play with my kids, I can move around quicker. So they are not very measurable, but they are significant quality of life parameters for the patient. Concerning the weight loss, I'd like you to look at this. This is a complicated equation, but it says the excess weight, the extra weight, is really your current weight minus your ideal body weight. So every height, which is fixed, every height has a corresponding ideal body weight. For example, if you're 5'6", should be around 150, 160 pounds. Okay. The current weight is what you weigh currently. The difference between those is the excess or extra weight. When we look at the success of the weight loss operation, we talk about the percent excess weight loss. And so what it is the amount of weight that you lost divided by the excess weight, and it's described in percentage. Just for you to see, the top line represents the gastric bypass percent excess weight, which is around 70 to 80%. I'm gonna kind of go over an example with that so you understand that better. The line bottom on the bottom is the sleeve gastrectomy, and for the sleeve it's around 65% excess weight loss, percent excess weight loss. What does that mean? If you pick the gastric bypass and you are 100 pounds above your weight, you're going to anticipate to lose around 75 pounds. If on the other hand, you pick the sleeve gastrectomy and you are 100 pounds above your weight, you would anticipate to lose 65 pounds. What about the complications? Those operations, the weight loss surgery operations, are very safe operations. This is an older study from the New England Journal of Medicine, multiple newer studies that kind of reinforce and echo those findings. But this talks about a death rate of 0.3%, okay? Current national numbers are around 0.2 to 0.3%. So weight loss surgery is very, very safe, and it's almost as safe as hip surgery or gallbladder surgery. What about the control of comorbidities? This is a very nice diagram. I borrowed this from the ASMBS, American Society of Metabolic Bariatric Surgery. But it looks at it kind of mentions all of the comorbidities that are resolved or improved. For example, sleep apnea is resolved in the majority of patients. Hypertension resolves in a good percentage of patients. Diabetes resolves in a good majority of patients. Non-alcoholic fatty liver disease, 90% improved steatosis, 30% resolution of inflammation, 20% resolution of fibrosis, significant difference. And this is why I think the importance of linking the treatment of obesity to the problem of fatty liver disease. Finally, the non-scale victories are what I had mentioned a little bit earlier. Running around, being able to tie shoelaces, a lot of parameters that are very, very hard to quantify, but they mean a lot to the patients. You're going to tell me, what do you think? Sleeve bypass, which operation should I have to lose weight? Okay, I tried diet, tried exercise, not working. Which one should I have? I hope I was able to impress on you that each operation has different profile on how it works. The complications and the parameters that come with each operation, we didn't elaborate as much, but sleeve versus bypass is your choice, really. It's the patient's choice. Most surgeons will let the patient pick the operation that they want, as long as there is no contraindication for that particular operation. In conclusion, obesity constitutes a major health problem. Bariatric surgery is currently the only effective and durable treatment option. Non-alcoholic fatty liver disease is a worldwide problem. I think it's a very, very underappreciated and more importance should be given to the problem of fatty liver disease. Please visit our website, www.bristolhospital.org, for more information about bariatric surgery. In conclusion, I'd really like to thank the American Liver Foundation as well as Bristol Hospital for allowing the opportunity for this event. I'm going to leave it to Donna, but I do want to mention something, please. In Connecticut and through the ASMBS chapter, we have a very, and through also the efforts of Senator Berthel from Connecticut, we are advocating for bariatric surgery coverage for all patients. There is some patients that do not where there is no coverage for bariatric surgery. Using this QR code, you can very, very easily, using your iPhone or Android, scan it, and it will write a letter to your senator or representative. It only takes a couple minutes, but this would be really, really helpful if you could support our advocacy for bariatric surgery coverage. With that, I'm going to leave it to Donna, I think, to conclude this this opportunity. So.
Thank you, Dr. Gedeon. I do want to express thanks to you for taking time to do this recording, and I also want to again express gratitude to Bristol Hospital for its sponsorship of this webinar. It's a very generous thing of them to do that, and we greatly appreciate that. If anyone needs further information about fatty liver disease or any liver-related matter, please feel free to visit our website, either the local one, which you see at the top, or the national one, which is liverfoundation.org. We also have a national helpline at 1-800-GO-LIVER if you'd like to speak with someone about any specific questions you may have. And again, thank you, Dr. Gedeon, for your time and expertise in sharing this information.
Thank you. It was my pleasure.